authorities more reliable, making systems people-centered and universal health coverage is health equity. The Millennium Development Goals, which was having those targets from 2015, 8 MDGs, 3 of them related to health: reduce child mortality, improve maternal health, combat HIV/AIDS, malaria, and other diseases. I don't know how much Indonesia was successful to achieve those MDGs. Then, these were followed by Sustainable Development Goals, which were much bigger and more ambitious, moving from 7 to 17 now. Yeah? And in these MDGs, the third MDG, the third one, which is this, is what is focusing on health. But all of them also have an impact on health, like when we say the determinants, reducing poverty, making sure there is enough food for everyone, making sure that gender equality is there, the quality of education, and so on. So what I want to share with you are the number 3, the health SDG. The health SDG, it had like 13 indicators. For example, it was to ensure healthy lives and promote well-being for all age groups. And the first one, 3.1, is the reducing maternal mortality. And it makes every country responsible by 2030 to reduce maternal mortality to less than 70 per 100,000 live births. The second one was about preventable deaths for people who are 5 years of age or under 5 years of age, so the children. And again, by 2030, to end preventable deaths of newborns and children under 5. With all countries aiming to reduce neonatal mortality to at least as 12 per 1,000 and under 5 mortality to as low as 25 per 1,000 live births. The 3.3 is about fighting communicable diseases. Again, commitment is to end the epidemics of AIDS, tuberculosis, and malaria by 2030. And for non-communicable diseases, it's to undertake reduction by 1/3 of premature mortality from non-communicable diseases through prevention and treatment, and promote mental health and well-being. Substance abuse, again, to strengthen the prevention and treatment of substance abuse, including narcotics, and universal access to sexual and reproductive health and family planning, again, to make this universally accessible by 2030, and to achieve universal health coverage that ensures financial protection from financial risks, access to quality essential healthcare services, and quality of affordable drugs. The 3.9 is reducing illnesses and death from chemicals and pollutions. Again, by 2030, all countries are expected to reduce the number of deaths and illnesses from hazardous chemicals and air, water, soil pollution, and contamination. Following Thus, there is 3.8 to implement the framework of tobacco control and universal access to affordable vaccines and medicines, increasing health financing and support of the health workforce in developing countries, and improving early warning systems for global health risks, especially the early warning to reduce national and global health risks. Well, SDGs were agreed, there was no COVID-19. But then COVID-19, as we have seen since March 2020, that pandemic has led to socioeconomic impact. It has affected the trust and compliance, and it has affected continuity of care. Because most of the hospitals, at least in the UK where I live, all surgeries, all operations, cancer care, everything was stopped, and all hospital beds were filled with COVID patients. So it has affected continuity of care. It's an ongoing info. And the idea of this vaccine nationalism, when vaccine was available, countries were trying to make sure that they keep it for their people rather than using it widely to give to those who cannot afford. The other part of important lesson that we learned from COVID is what we call the decolonization of the global health. To make sure that I have been discussing yesterday with a lot of your colleagues and your teachers who are saying, can we raise our publication profile? In the past, most of the big journals were accepting papers from authors from rich countries, from developed countries. And even if the research is done in places like Indonesia, you will always find the authors or the first author, the second author will be from high-income countries, and you will be somewhere at the bottom. So this decolonizing global health is to ensure that authorship in academia is given to people who use them. It also includes, for example, dismantling schools from the old colonial legacies. We use in the Nafri people who came to us, we use a lot of examples in our teaching from low middle income countries, rather than the UK and America and so on. The same thing here, we are saying we need to dismantle the old legacies. And for example, the global cooperation now is only succeed by itself. London School of Hygiene and Tropical Medicine has got now a team called Decolonizing Global Health. And these are some of the examples that are ongoing. So with that, I hope I have covered all the 4 issues which I said I will share with you. Determinants of health, health and health system, and the challenges they face, how policies have responded to these challenges, and I have given some example of the global trends in the health policy. Happy to take questions and discussions. I will stop and have some water.
Very much, Dr. Mani, and ladies and gentlemen, please once more big applause for Dr. Mani. quite dream, and my dreams come true to see in him teaching him. And it's a very nice topic that we move smoothly, started from the historical of the health system, started from the health developments and health challenges, including mental illness, which is quite new topic that because it is most neglected area in health system so far, and also the human resource issues about the migration of the human resources, and also Dr. Maya has shown us about the framework from the Professor Andrew Green about how to deal with those challenges, and also the principle of primary health care, and also the colonization of global health, which is also new. And it brings many insights for us, especially for health issues and system. So, ladies and gentlemen, please, now we are opening the questions and answer session. Any questions? Don't worry about the language. You can deliver your question or comments in Indonesian and Bahasa Indonesia, and I will try to translate. Ya, bisa bahasa Indonesia. Jadi kami coba translate. There are two things. If there is no questions, you understand it very well, or you don't understand either one. Super.
What I suggest is, even if you understood everything, I would like you to challenge some of these things you have, what you understood, things that you don't agree, and things that you want to discuss more. Because remember, I said, I'm also learning. To what extent are these topics that we have shared relevant to the context of the business? How can you make sure that you understood the determinants of health, and in your public health teaching, in your hospital management teaching, so that you see health broadly than healthcare. And then if we see health more than healthcare, what are the challenges that we are facing to ensure that people are healthier? And how can we respond to those challenges in regard to setting up policies, reforming our health systems, and in using that framework which I mentioned, the policy triangle, looking at the governance, looking at the resources, financing, and also the service provision from the healthcare perspective. But also remember the outer bit, the workers and patient, and most importantly, the role of the community. Similarly, these international policies that are up in Geneva or in New York or in Ghana and then imposed on countries like ours, to what extent are they relevant? To what extent can we say the way these policies are set are good, but we let some freedom to shape our own that is compatible to our culture, with the resources, with our level of understanding, with our healthcare systems. Then most importantly, how can you be part of this decolonization process? Rather than us being always told by those who think they know better than us. But also we forcefully say, no, we want to be part of this game. We want to also be in the publication of the information that is gathered from the research. We want to work together as people. So these are the things I would like to challenge and to come up with some suggestions, some solutions, some proposals, even if you have understood everything.
Okay. Is there any question? Yes, from behind first, and also from Ibu Rumala, and at this side. Okay, 3 questions.
Use your mic.
Would you please move in line, Sujita?
Bismillahirrahmanirrahim. Excuse me, sir. Thank you for the opportunity. Let me introduce myself. My name is Aditya Pompis. I just come from Tiongkok, actually. And my question is about the colonization of the global health. May I know, is it have the comparison for any other country for the colonizing the global health? And is it the global issue? And we not together what we don't know how to against, how to face it. And then my question is for example, in just now in G20, one of the program priorities about global health, even they talk about recover together. And then actually in every country they have their own public policy. And then how about the comparison of any other country about the public policy? And if it possible to make the international globalization, if it any lot of stakeholders in any country, they have the authority in each country. Thank you, sir.
Thank you, Aldi from Tiongkok. And I think we move to Ibu Rumala, please.
Thank you, Bu Alifa, Maria. I'm interested with one of slides which explain about how human resource challenges with Dr. Maria has shown us about the countries with critical shortage of doctors, nurses, and nurses. I see the mass and Indonesia also one of the countries with critical shortage. The pandemic, COVID-19 pandemic, Indonesia also faces this condition. We have critical shortage, especially disparities in the Western and Eastern Indonesia region. But during COVID-19 pandemic, we lost many doctors, nurses, midwives, and it's become more critical shortage condition. Do you have any ideas about how to accelerate our Ministry of Health have transformation of human resource, how to accelerate the critical shortage of doctors, nurses, midwives? Do you have an example how to accelerate the shortage of human resource, particularly maybe from university roles or and stakeholders? Thank you.
Yes, thank you, Rumala. And I will move to the next question, please.
Thank you for kesempatannya pakai bahasa Indonesia dulu. Jadi saya mau nanya 2 pertanyaan.
Boleh namanya dulu.
Nama saya Khairul Sudirani dari Mas 05. Nah, saya mau nanya Bu, yang pertama, kan Indonesia ini, saya tertarik dengan pembahasan 20 penyakit dan MDGs dan SDGs tadi. Untuk Indonesia kan belum semuanya tercapai. Salah satu permasalahannya adalah Indonesia ini adalah negara yang kepulauan, dan kesulitannya di Indonesia ini akses untuk kesehatan di negara kepulauan tersebut itu susah. Nah, ada salah satu solusi yang pernah dikeluarkan oleh Dr. Lee, itu rumah sakit apung yang di kapal, dia menggunakan solusi tersebut untuk mencoba supaya menjangkau akses-akses yang dikelola tersebut. Nah, menurut profesornya sendiri, apakah rumah sakit apung itu solusi terbaik bagi Indonesia yang negara kepulauan ini gitu. Terus kedua, banyak sekali pembangunan rumah sakit yang ingin goals MDGs atau penyakit yang 20 penyakit tersebut itu tercapai, tapi untuk segi sudut pandang lingkungannya sendiri, lingkungan kita yang sekarang krisis mulai semakin lama semakin polutan semakin tinggi itu tidak di concernkan. Menurut profesor sendiri itu bagaimana caranya kita membangun kesehatan yang ramah lingkungan. Terima kasih.
Okay, my is from Fairuz. He's a student from Master of Hospital Management program batch 5. You presented 20 diseases and SDGs and MDGs, and Indonesia is one of the countries who are struggling in achieving the target of SDGs and MDGs. And this is, according to her, one of our obstacles is because we are archipelago countries, lots of islands, and these lead to a limited access for the people to access the healthcare services. And how there is a solution by Dr. Lee about floating hospital by using the ship. And what do you think about this? Is this the best solution for healthcare accessibility for people who live in the island? And also for Indonesia, which who has many islands and archipelago countries. The second question is, there are many hospitals that trying to reach the target and to contribute in reaching the target of SDGs. But it comes also with the environmental issues about the pollution. And could you give advice about how to develop a health system which is environmentally friendly? Thank you. Is it different? Thank you. Okay, Dr. Maya, please respond for first 3 questions.
Thank you. I see this as contributions to the discussion. Dr. Maya coming from UK is not having solutions to problems. And we never give you solutions to it. This doesn't have solutions. It makes you come up with your own solutions. And always, these 2 students I have here, I remember we always used to tell them there is no right or wrong answer, or no right or wrong solution. The solution that you are proposing needs to be appropriate and it also depends on how you make a case, you convince, how do you propose, and who do you involve in accepting your solutions. Let me start by decolonization. Let me proudly say that the North, in this case the West, Europe, America, Canada, wherever, there is a lot that they have learned from us, from developing countries, which they are using as being something that they invented themselves. We hear stories like so and so Vasco da Gama came to Tunisia and discovered some part of Indonesia which already existed. So these people are very good in promoting their ideas. For example, the oral rehydration therapy for treatment of diarrhea was in the first time tested and successfully found to work in Bangladesh. And this Bangladeshi offer to use the oral rehydration salts to treat severe diarrhea now became a norm for the treatment of diarrhea all over the world. So I want this to be decolonized. I want this credit to be given to Bangladesh, to Indonesia, whatever. Another example is the idea of community health workers, the non-medical professionals, who are from our experience, and I think this is relevant also to the islands you mentioned about. Which when we started to work this, what seemed to be quite alien. Now, I'm speaking now, most of the countries, Germany, UK, they have introduced a new class that they call associate physicians. So not doctors, not nurses, but people who are trained to provide primary health care because they cannot afford to produce doctors and make these doctors available. So this is an interest, and this credit needs to go to where this has come. The authors of this work are people from low income countries, from developing countries. So they need to be part of this, and they need to be acknowledged. And when this is published, they have to come up prominently. I think historically, when people go to work in Western, to study Western countries, they hope that they are going to learn how those countries, for example, how do they deal with these issues, with these things. Fortunately, the way they deal with different things does not suit us. It's not relevant to us. What we need is to learn how they deal with these and those different things, and then we come up with our own ways of dealing with it. Keep considering the context. We always say context is important. Yes, the global stakeholders, WHO very important, global stakeholder, World Bank very important stakeholder, donors, for example, UK, Dutch, Germany, all these are important global health stakeholders. And the important I mentioned here about the sector-wide approaches is rather than them dictating to you what you should be doing, you say, give me the resources, help me. I know how to address my priorities. So that was one thing. The issue about critical shortage, again, there is critical shortage in Indonesia, there is critical shortage in the UK, there is critical shortage. It is not fair that the Indonesian nurses are playing by the government pay for their education, and then they have to qualify to go and work in countries for free. It's not fair. Now, these critical shortages, how can this be addressed? I mentioned some suggestions. One of the suggestions, for example, is to come in Indonesia, very context, can we sign contracts with people when they finish, when they graduate to say, you must work for your country for X number of years. Another interesting thing I will tell you about my own experience from when I graduated from the country I come from. We because the government used to pay for all our education from primary all the way to the university for free. And then when we graduated, we were never given our degrees. Government will keep our degrees, and you cannot escape without a degree until you finish the term. Then when you finish the period that you are supposed to work for the country, you can apply for a degree and you will do where you want. It did work. Some countries make sure that the qualifications they are giving to their graduates are not compatible to the international standards. But unfortunately, we all want to be international standard, as we are working for global people for other countries. I think there is a benefit in your qualification not to be internationally recognized. You train your doctor with the skills he needs to work for the people of the country, at least to start with. And then, for example, this cadre I was mentioning, the health assistant, the medical assistants, they were having qualifications that were not recognized in other countries, so they cannot go and work. So these are some of the approaches you can consider. Definitely, training more is always a good idea because I come from human resources interest. People die, people retire, people leave, people stop working, people they get sick. And this we need to start, we need to think about their placement. So always training more and more and more. And the needs and the needs as well. MPG, Indonesia is struggling, lot of islands, limited access to health services, using ships. Yesterday, when I was introducing myself, I said that I come from a background of nomadic area. Nomads are similar to these islands. These are people who live in desert areas where there is shortage of everything. Vast country, no roads, but they need healthcare. Access is a problem. And some donors, like what they did to you, suggest ships, they suggested us to use helicopters. Flying doctors, they used to. Yeah. So we use helicopters and we go and we prize them and we come back, we go and help them. It's not the solution. When I did my thesis, and when I did my master's in provide healthcare to people in scattered remote areas, one of the approaches I suggesting is selecting among themselves people who are trained, who then are working back to their own people in those islands, in those nomadic communities, and so on. And because if we train them to address the priority health issues, it will be sufficient. And then for complicated cases, thanks to COVID-19, you can always call the nearest hospital, the nearest city, the nearest island, and seek advice. I have taken this condition, I tried to do this, so it's like prominent. So, online consultation. So I think coming up with your own approach, providing access to the island people, nobody has that experience. We have to come up with our own approach and come with our own experience. the hospitals are contributing to achieve the SDGs. However, can you elaborate what environmental friendly are you looking at?
Dr. Bagus, would you please elaborate, bisa lebih dijelaskan lagi yang seperti apa yang environmental friendly tadi yang terkait dengan rumah sakit?
Contohnya kayak kimia, kan kadang setiap rumah sakit itu tidak sesuai pembuatan rumah sakitnya tentang pembuangan limbah, terus sampah-sampah medis, terus juga pembakaran sampah-sampah itu kan semua polusi ya. Jadi terkadang nggak semua rumah sakit itu melakukan environmental fokus ke lingkungannya itu tidak sesuai dengan yang harusnya seperti itu tidak dilakukan gitu. Jadi baiknya seperti apa dari sisi regulasinya, dari sisi rumah sakitnya itu memang harus fokusnya gimana untuk tetap mencapai target itu. Pasti.
Okay. Hospitals produce chemicals pollution and medical pollutions in the garbage. And there are some hospitals, I believe some other hospitals that will manage their chemical pollution. But sometimes hospitals, they do give treatment to cure people, but their pollution has polluted environment as well. And these environmental issues is complex as well. So do you have any best practice that you can share?
Yes, waste management is a big problem. We produce a lot of waste everywhere. In our houses, we produce a lot of waste. We clean our house, but then we produce and we destroy our people's lives. Same with hospitals. And there are exposures. Not affecting it. It is the topic by itself. I will mention there is another hospital that is doing quite well. I think learn from them. But it's not only about learning, it is about telling the leadership of the hospitals. So those people who are managing, new people who are going to be hospital managers with master's degree, need to reinforce these approaches for appropriate disposal system. Learn from others who are doing it well, because the way they are exposing their waste maybe is appropriate for this context of Indonesia. So it's better to, rather than someone from Europe coming and saying this is how we do this, which you will not be able, you might not have resources. It might create another side effect of the way that they. So unfortunately, I don't have a solution, but I think the solution is here. By learning from each other, it's always mentoring each other. For example, we talk about exchange. So, exchange of students with universities and the university here. Why not exchange managers? Hospitals in Kasar, for example. goes there, observe, see how they are doing.
In response to your questions about, can we sign a contract and we ask the people that the application is.
Thank you, Dr. Ravi, and please, Dr. Maya. Is it one more? Yes? The sixth one? Oh, okay. Yes, silakan.
Thank you. I am Yulianti from Hospital Management Department. My question is, how about government policy related primary healthcare in UK? Like intervention government, intersectoral coordination, and budget finance in UK about primary healthcare. Thank you.
Thank you, Dr. Julia. Once more. Yes, this me, please.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity and thank you very much for Dr. Maya for the comprehensive presentation, especially about the determinant of health. And I think we already agree that most of the determinant is a problem in Indonesia. And one of my concern is about a policy, and especially according to what the first the Dr. Adi questioned about smoking behavior and also about the environmental analysis. I think one of the problem is our in policy stage development in Indonesia is about the policy enforcement, and we are very low in enforcement policy, especially in healthcare and also the environment and also about smoking behavior. Based on my experience, I'm working as one of staff in public health faculty, working in NCD prevention, especially for smoking behavior. And our problem is always about policy law enforcement and also a lifestyle, how to change Indonesian characteristic. The lifestyle, and I would like to ask for suggestion from Dr. Maye, based on your experience, how to solve this problem. Thank you.
Thank you. Please.
Thank you. I will combine your because they are related. You see the Islam, our religion, alhamdulillah, gives us guide. Referring this to the time of Prophet Muhammad. When alcohol was a problem, everybody was drinking alcohol. And this alcohol issue was addressed quite neatly and strategically until it was stopped. We Muslims seem to learn from that example. But fortunately or unfortunately, it is the non-Muslims who have used this to enforce the smoking policy. Let me give you an example. I don't know if this is relevant here. For example, in the UK, smoking was a problem. They came with laws slowly, one after the other, not all at the same time. Stop smoking. No. It was limiting, for example, they started by saying, you are not allowed to smoke in your office. Before, we sit in our office and don't smoke. Now we are not allowed to smoke in the office. But you can get outside your office and smoke outside. And they made a shed. So outside, in open air, they made a shed. People every now and then they go and stand there and smoke and smoke and smoke and come back. So the frequency, every time standing up, going to smoke, and UK is very cold, especially this time of the year. So you see people when they go back. So they started this. Now, the University of Leeds, it's a big campus, is all smoke-free campus. Not allowed to smoke in the campus at all. So it started by not smoking in the office, then not smoking in pubs. You know, British people, they go to pubs. In the university, they have a student union. There are many pubs people go to drink and to smoke in the evening. They stop, but they say in crowded places you cannot stop, you cannot smoke. And now it is the whole campus you cannot smoke. The same policy was used in airlines, the airplanes. Now, all airplanes, you can travel from UK to Indonesia, it's maybe 20 hours, you are not allowed to smoke. And this has reduced the demand for smoking. People out, nobody buys cigarettes. So the idea of people stopping production of cigarettes is not feasible because you cannot, there is that freedom as a value. But people, when the demand falls, then those companies stop producing cigarettes. Instead, they will produce something else. Unfortunately, here, we are not using these lessons of Islam to introduce bad habits. You go to a restaurant, loud music, everybody is smoking. What about the government can make these rules to say you cannot smoke in restaurants, you cannot smoke in public places, you cannot smoke in the offices, you cannot smoke in the rooms because we are not allowed to smoke in our houses because there are children, there are family. It's illegal to smoke in your house. So this can also be if you make a policy, it has to be reinforced by law. So in order to implement that policy, you have to make it an offense if it is not followed. So if somebody is caught now to smoke in the university or campus, he will be taken to court because he has broken the law. If you smoke in the toilet, you have broken the law. If you smoke in your office. So there is the enforcement of that policy in making sure that it is implemented. But to have a policy and then not to follow it through, not backed by law, and policy cannot be made by the Ministry of Health, unfortunately. It has to have and that 300, for example, I was sharing, it has actors. Who are the actors who can develop, implement, reinforce, apply, use? All those have to be involved in the development of the policy. So Ministry of Health alone sitting and expert writing the policy, it will only be kept on the shelf. But bringing all the actors and policy development is really very tedious. It takes years. We do stakeholder analysis, we do field force analysis to see how powerful are the different stakeholders, who is supporting, who is opposing, how can we influence the opposition to make them support the policy. and then it becomes a policy for everyone. So that is an example I can share in terms of the application of policy. And it's not only smoking, it's also about other policies. If you are introducing a policy for usage terms, then it has to be reinforced. If you are introducing a policy for quality assurance, then it has to be enforced. Somebody has to monitor and to take action if it is not followed. Human resources policy, they need to be followed. The point about the values, I listed those values as an example of values. No one, you has only their values. So I will say example, and I will say these are examples of values. And these are the values that we as policymakers, depending on which these values we have, will influence us in making the policy that holds that value. For example, if minister believes in health to be the right of every citizen, if the president believes that health is the right of every citizen, if this is enforced in the constitution, in the law of everyone, then the policies that are developed will make sure that health will be provided to everybody regardless. If people who are making a policy has a value, and that is why, what is your value as a policymaker? So that is just an example. PHC in UK, somebody asked me an example. How to do PHC in rural areas. Yes. Yeah, I think somebody asked the policy of UK, sorry, primary health care in UK. My next session, I will talk about the UK health system. I will mention about primary health care. The disparity, everyone mentioned about disparity between access and quality in rural areas, how to improve female literacy. Very important. Often, from my experience, it is not easy in a country which has limited resources to have both good quality and good access. You have to choose which one you want to focus. If, because you have very little budget, very few healthcare professionals, if you are interested in improving access, then that access does not necessarily have to be of high quality. It is like better something than not having it. But then, once the access is improved, then the next step is how to make the quality improvement. I think issue about female literacy, yeah, and female literacy. It has to be the policy of the government of the country. If you live in Afghanistan, unfortunately, the government doesn't want female to be educated. Argue for the literacy in Afghanistan, you are wasting your time. So it has to be a government policy and the Ministry of Education policy. Make sure that female literacy is not necessarily about health, but about general understanding. And in your country, from what I see, female running around working, studying, I think it's not a major problem, but it is important. information about the hospital that she is working and the confusion of the government regulations. New minister comes, changes the policies by issuing decrees, yeah, changing the requirements. But there is already a policy saying that these requirements level 2 and that level 3. I don't know if ministers they are making life difficult for people, whether they are making it easy for people, but that is not what policy is. Only change the policy if you feel old policy is out, because policies change. The needs, the context, the demographics, the epidemiology, everything changes as we have seen, as we progress. So if there is a need to reform or revise the policy, adapt the policy, we change it. But if it is just for the sake of you to have get rid of all policy, this is not what policy makers like us or policy analysts. UK, the NHS, where I come from, they do change every new government. We have two parties for one time groups, another time conservative and liberal. So every new party they try to reform the NHS, change the administration, but the general policy of the NHS of providing free healthcare to people, it never changes. What changes is the management. So that is the other issue you mentioned is about the production of doctors. Is it the production of doctors or is it the problem of distribution? I think the problem is there are a lot of doctors where they are not needed and there are no doctors where they are needed. And this is a phenomenon of big cities and for a number of reasons. Okay, I think I addressed most of your concerns and I responded to your comments. Again, I'm not giving you answers, I'm just highlighting how we can.
Thank you very much, Dr. Maya. Alhamdulillah, I think we need to end this session, because our second session to me is, I'm more curious about the second session. It's about global health system in comparison between UK and US system. So maybe it could answer your questions, and also others question also be more elaborated in this topic. So
let's give respect to everyone. Maybe walk with me.
yes, I think it's okay. So ladies and gentlemen, we will have a short break for about 10 minutes. Please take your time to use the restroom and to move around just to avoid the sickness. Okay, so we'll be back at 11:30. Thank you. Bagaimana jika ada snack di luar, silakan diambil saya di luar, boleh makan di dalam. Tapi yang perlu kami informasikan nanti setelah makan, tolong bosnya dijawab ulang lagi. Assalamualaikum, saya sudah selesai absensinya. Menyatakan itu dan saya meninggalkan. Kalau ini nanti
Kapan lagi kita pulang?
Bismillah, ladies and gentlemen, ladies and gents, all our beloved students, when you return back to the Senate room, we are going to have the second guest lecture for today.
Okay, the next session is continuing the global health systems, and I am going to use two examples, UK and US. The idea why I want to use these two examples, because both these countries are considered developed, but they have different health systems. And I want to share with you these differences between the two health systems. I want you to judge which one is better and why it is better. So when we finish the session, I would like you to say which one of the two health systems you think is better and why you think it's better, one or the other. So we will vote. So the objectives of this session, we will discuss the development of global health systems. So we will pick from where we left. We will discuss using the examples of US and UK. And we will discuss the policy management issues in the two health systems. And also, what I want you to do is to draw lessons from these two systems, something that you can use for your future, the course that you are doing, in the discussion that you are having, and also which one works where and why. I want here, in the introduction, you see this man here on the bicycle. And if you know that man on a bicycle, you know this man here? This is a colleague of mine. His name is Tom Desofi. He is someone who worked with me on the hospital. He was the director of hospital management program. And some of the information I'm going to use in this presentation comes from his experience and from the work that he has done. So I want to acknowledge Tom in this session. What we have here is a health system, an example of a health system, which we will come back to. Here in the middle, you have the community, which includes, for example, primary health care, which includes self-help groups, which include other sectors, social services, and then outside the community, you have a number of services. Some of them are specialized services, some are diagnostic services, hospitals here, the non-governmental organizations, specialized prevention services. So they all are working to the community or for the community. In these models, I'm going to use these two examples. One is called the Beveridge model, and the other is called the Bismarck model. Remember these two models. The Beveridge model is based on healthcare that is provided and financed by the government through tax payment. So the government collects taxes from people, and the government uses these taxes to finance health and to provide healthcare to the people. And this is what the UK model uses, is the Bismarck model. The other model, which is called, that is the Beveridge model. The Bismarck model is based on healthcare that is provided through insurance. It is financed jointly by the employers. That means people who are employing the staff and employees, and also the staff themselves, the workers. And this is deducted from their payroll. So every month when they go to get their salary, some money is deducted from them to pay for their insurance, and the employer also contributes to that pocket or to that pot of insurance. And this is called the Bismarck model, which is more or less what the US system uses. Just to recap, all together, for example, from 1945 to 1960, both in Africa and in Asia, there was decolonization. A lot of countries were becoming independent in that period. What time did Indonesia gain independence from Dutch? 1955, 45. So my country got independence from Italy in 1960. So that was the period when most of the countries in Africa and Asia were getting their independence from those who used to colonize them. And what does it mean to be decolonized, to be free? And how was the healthcare delivered at the beginning of that period? For example, during the colonial powers, what type of healthcare was there? We know that there were hospitals built in cities where the foreigners, the people who are ruling those countries, usually resided. And then in remote areas, especially in Africa, there were mission hospitals. There were Catholic, Protestant, church-based hospitals who were serving the rural populations. And then there were traditional healers in many of these countries. For those who are not covered by mission hospitals and colonial hospitals, they used to go to traditional healers. And every country has some sort of traditional healers. For example, if somebody breaks his hand, there was a traditional healer who would fix the bone. If the child is having diarrhea, there is a traditional healer who will treat the child of diarrhea. If somebody is having mental health problems, there was a traditional healer who people will contact. So that was the period, 1945 to 1960. And then, following the independence of these countries in Asia and in Africa, the global health policy and health systems started to develop. These countries started to develop their own health systems with the help of UN agencies such as WHO, World Bank, or even international development partners and also national governments. Then we mention about the primary healthcare, the Alma Ata Declaration, 1978. It was sponsored by WHO and UNICEF in Kazakhstan. All ministers of health have attended, and the goal was to achieve health for all by the year 2000. And it was focusing not only on healthcare, but also on health and development. And there, with the primary healthcare, there was a major shift in the health ministries throughout low and middle income countries, because the primary healthcare was emphasizing intersectoral collaboration, it was emphasizing community participation, and it was introducing primary healthcare approach based on that. In 1990s, because of the economic recessions and because many governments felt that primary healthcare with all its components was very expensive to provide for free. So they introduced user charges. User charges is a sort of private healthcare where people, when they go to seek treatment, they are charged for the services that they receive. And the idea is this money was to be used to buy the medications, to pay the incentives to the health workers who are feeling to be underpaid. It is also called out-of-pocket expenses, and it was introduced because health workers were very demotivated, and the money that was generated used to supplement the income of the health professionals in many countries, and it is still being used, these usage charges in many countries. In 2000, the problems of user charges were felt because the approach itself became inequitable for people who cannot afford. It was inequitable. There was a problem of access. If you are charging people, then healthcare was not going to be accessible to all. And then things started to change from out of pocket to third payment, which is another third party pays instead of you paying when you are sick. So, and that is another term which is called, for example, reimbursing for the medical care claims and expenses is another form of insurance. So instead of paying when you are sick, you contribute, and when you go and seek treatment, you can claim for reimbursement. And these include government agencies, also it includes insurance companies, as well as health maintenance organizations that are known as HMOs. Then we are recently facing or coming up with this idea of universal health coverage. And the universal health coverage is being introduced because there was an issue about equity and coverage to make sure that people receive health care, or the health system is set in such a way that people are protected from paying when they are unable to. And so it introduces the idea of risk protection and improved access to health and improved health outcomes. This initiative was introduced by WHO, and it is part of the United Nations Sustainable Development Goals that we have discussed earlier. And the Sustainable Development Goals have a target of 2030. It's really soon, these next 8 years, I hope we will not disappoint ourselves. So you will see here in this picture the world in colors. The green part in the picture, what you will see are countries who provide free healthcare, and all these countries are known to be providing free healthcare. So you can see all countries of the former Soviet Union, Australia, some of the South American countries, and Canada as well. And then you have got the blue color countries, which are the countries that provide free, but not universal. So these countries, they provide some sort of free healthcare, but not for everything. People still have to pay for some type of healthcare. And then you have the red ones, which do not have free and do not have universal healthcare. So you can still see that some countries here some countries in our part of the world some countries where we are located here, they are also having that problem of not having free and universal care. A lot of African countries, as well as the United States of America, it is not providing free and universal health care. So with that introduction, I would like to introduce now the examples of UK and United States health systems. United States, it is here, consists of 51 states. The United Kingdom consists of England, Wales, Scotland, and Northern Ireland. And if I may start with the United Kingdom National Health Service, it has very clear objectives. The National Health Service in the UK was developed in the 40s to secure the greatest improvement in the physical and mental health of the population by promoting health, by preventing illnesses, by providing diagnosis and treatment, as well as injuries, and caring for those with long-term illnesses and disability. It is a service available to all, available to everyone, young and old, even students who come to study, even refugees who come legally, based on their clinical need, regardless of their ability to pay. So they are not required to pay anything. If they need health care, they get it at the point of delivery. And the performance of the National Health Service is assessed based on the three headings, which are equity, efficiency, and responsiveness, making sure that the services is equitable to everyone, it is efficient, and it is responsive. Just to give you a brief history of the UK National Health Service, it was established by the Labour government in 1948. And before 1948, the UK had a combination of voluntary services and private services. It was founded on the principles of a welfare states following the Second World War. Again, a welfare state is an arrangement that everybody in the UK is entitled to a house, to food, and to healthcare, whether you have money or not. Even if you don't have a job, when you don't have money, it is the responsibility of the government to provide accommodation, house, to provide you basic income so that you can survive until you get a job, and also you get health care when you need it. NHS provides health services to the population, as I said, in England, Scotland, Northern Ireland, Wales, but they are managed separately. You know, these 4 parts of the UK, they are decentralized. So they are having their own local governments and they manage their health care. And they introduced reforms in 1990s, which is internal market structures, which made policy of contracting between health regions and as a purchaser and healthcare providers through health districts. Let me explain to you this concept of purchaser-provider split. Before 1990, the NHS was providing the services, was funding the services of all sorts. In 1990, they brought in market approaches and reforms. So they introduced what we call public-private partnership, purchaser-provider split. They separated the purchaser, which is the government, in this case the regions, Northern Ireland, Scotland, Wales, and England. They purchase health services from the district providers. They pay for them to provide service. So there was that distinction between who pays and who provides. This diagram is a little bit small for all of you to see, but what I was trying to show is the reforms to show you the old health system and the new health system. For example, in the old health system, it was structured in this way. There was the Secretary of State for Health, who is like equivalent to the Minister of Health. And then, under the Secretary of State for Health, there were 10 strategic health authorities. And in all these strategic health authorities, they had 151 primary care trusts. And these 151 primary care trusts, they had hospitals under them, general practitioners, mental health units, dentists, community services, for example, district nurses. They all were part of these 151 trusts. And then the patients. It was reformed in 1990 into this type of structure, which, for example, replaced the strategic health authorities with NHS England, NHS Scotland, NHS Ireland, whatever. And then these NHS England, for example, had 211 clinical commissioning groups. These are the groups who will commission others, hospitals and general practitioners to provide services to the patients. So these will be the purchasers of services from hospitals, from mental health units, from community services, from general practitioners, therapists, specialists, and ICUs, in order to provide care to the patients. And then here we have the Parliament, the Public Health England, which looks at the preventive side, and then the public health services in local authorities, and then the general public. So just to give you an idea that even in UK, you mentioned, somebody mentioned earlier, when the Minister of Health changes, he changes all policies. So even in England, or UK, they change the approach or the management of the National Health Services. But still, they did not change. They still did not change the fact that whatever structures that were in place, they were all providing healthcare to the population. Now, the current structure, we have clinical commissioning, which I say, who are responsible to provide clinical leadership, helping, which is providing clinical leadership to deliver quality care that is responsive to the patient's needs. They contract for services with general practitioners and primary care providers, public and private hospitals, community care and mental services, and they work in collaboration with local council for social care as well as school. I want to explain what does this mean. You have seen here me mentioning private hospitals. So the private hospital in UK or in England is there. People can choose to go and get treatment from the private hospital if they wish, if they can pay, because they want to get very quick treatment, otherwise they don't want to wait. But your doctor also can refer you, for example, to be treated in a private hospital and pay for your treatment. So, for example, you need an operation, an elective operation, surgery. You have waited for a long time, your appointment was cancelled in the public hospital. Your doctor can refer you to a private hospital so that you can have your operation done and the expenses are covered. Because it was the government who failed to provide you timely treatment. So there are private hospitals, and these private hospitals, either people choose to go by themselves, there are people who have insurance, for example, or the government will pay for your private health care. The last point I mentioned about working in collaboration with local councils. Local councils themselves are the municipalities, because in UK, provision of social services is the responsibility of the local government. So I was mentioning about the local government, which is called the local councils, are responsible to provide social services to the population, which means chronic for people who have disabilities who cannot be kept in the hospital for a long time, but they need to be provided care at home. So these National Health Service will transfer these people to the local councils or local governments, as well as school health. The way NHS is funded, as I mentioned, it is based on taxation, which forms 80% of the funds for the NHS comes from taxation revenue. That is the tax that is collected from people who are working, it's deducted from their wage, and also from the sale of goods, from other means. 13% comes from national insurance, and 7% comes from fees and other sources of income. The allocation, what is the funding, like we mentioned earlier, is the production of doctors and and nurses and so on. But then is the allocation of those doctors. So the money is being collected from people. How is this allocated to different districts, regions, hospitals, and so on? So the allocation, there is a formula for allocation, and this allocation is based on capitation. For example, for doctors, the general practitioners, they are given money based on the number of patients who are registered in their facility. So the government has got a calculation to calculate that. It also is based on the health needs as well as area of residence. Like in the Philippines, somebody told me, the East is a little bit underdeveloped compared to the West. So in that case, in UK also the North is underdeveloped compared to the South. So the resources will be given, more resources will be given to those who need the most. So it's based on also the residence, socioeconomic status, the current baselines, and also the case of change. So the ability of the clinical commissioner groups to respond to changes. The thing is that the government is proposing targets. You have to treat so many patients. You have to reduce the waiting list to that percentage. You have to make sure that everybody is seen in 2 months' time. So those who achieve those targets get more allocation. So it's like an incentive to provide to people who need the targets. And that is, for example, the money comes from the King's Fund. It moves around all the way here to the clinical commission groups. And you can see the amount of money is really huge, 130 billion, and all the way to groups. You will see these slides better. And this is how the money flows and how this is monitored, for example, safeguarding choices, licensing providers, managing failures, setting national tariffs, and authorizes foundation trusts. The spending in the NHS planned spending was 190.3 billion in 2021 and 22. The majority of this was transferred to NHS England for improvement in spending, and the Department of Health spending includes 33.8 billion to respond to the COVID-19, for example. That was in addition to the 190. And then the National Audit Office reported that parts of NHS seriously have financial instability. And the NHS was in deficit of 780 million. So even with that money, there was deficiency. And this shows, for example, in the during the 2020 to 21, these are the additional money that was given because of COVID. Otherwise, the trend is constantly growing every year in terms of the allocation and the funding of the NHS. The human resources element, just wanted to mention that NHS is the largest employer in the world, not only in the UK. It employs people from all over the world. It employs around 1.5 people, and headcount basis each individual member of staff and 1.2 million of full-time equivalent. Same thing, NHS Scotland, Wales, and Northern Ireland also employ 161 and 884,000 people respectively. The current crisis on working conditions for junior doctors, for example, consists of 1/3 pay increases on average by 30 to 58. Increase in working hours, including Saturdays, loss of staff as a result of COVID. These were the critical things that the NHS staff have accounted for. There was the need to increase pay. And also the junior doctors were required to work more than the senior ones, to work even on Saturdays. And a lot of people died because of COVID-19 pandemic, and as a result, low motivation, which you can hear these days. There are a lot of strikes by nurses and ambulance workers in the UK. The quality of care is considered to be good so far. Before coronavirus, for example, the issues included poor quality of care that was hard to plan. There was a need to deliver more joint up way, and then there was continued fragility of adult social care provision. These are the people who are provided care at home. There was a struggle of the poor services to make any improvements. There was significant gap in access to good quality, especially mental health aspect, and also persistent inequality in some aspects of care. State of care, as per the moment, is we all know that the COVID has impacted the way health services or social services are delivered, and it has damaged the services because of the issues we all know. There are more groups who are facing accessing issues and who are complaining about receiving high quality care. People with learning disabilities, for example, are facing increased challenges as a result of the pandemic, and the need of mental health care has increased. Health and social care staff are exhausted. The strain on carers, people who are caring for their relatives, are intensified. Still a positive feeling about care when available. So despite that, people still feel positive. And for example, these are the type of healthcare providers that the NHS currently is having. Those are the numbers: 155 active trusts, 56 mental health trusts, 34 community providers, 10 ambulances. It's all based on trusts and 800 GP practices, and 853 for-profit and not-for-profit independent sector organizations that provide care to NHS patients from different locations. The strategies, this was 2019, included boosting out of hospital care, redesigning and reducing pressure of emergency hospitals, people getting more control on their own health, digitally enabled primary and outpatient care, and local health organizations focusing on population health. I said I will talk about the NHS primary care. NHS is not designed according to the primary health care philosophy, not those of Alma Ata Declaration. Public health and primary health care and public health are seen as two separate things. Okay. And the government policy is to achieve primary care driven service. Primary care is very different from primary health care. It is the way services are provided. And they include, for example, 90% of patients to contact their GP practitioners, primary care covering dental practices, community pharmacies, and optometrists, the people who check for your eyes and so on. There is a system to monitor the improvement of quality in the NHS. There is an institute called the National Institute of Health and Clinical Excellence. This is created to be responsible for improving the quality. For example, the NICE, in summary, it produces and disseminates guidelines, and it promotes cost-effective clinical care and advocates standard treatment protocols. So NICE, or the National Institute of Health and Clinical Excellence, is responsible to develop protocols that all the doctors have to follow for treatment of different conditions, to make sure that the services are cost effective, there is no loss, and also monitoring the sector regulator for health services to protect and to promote the interests of patients. And these are the mechanisms for improving quality. There is Health Watch, which identifies any problems when they arise. It recommends changes in that quality, and it holds those who are responsible for making decisions to account. And then there is also the Care Quality Commission that regulates all health and social services, including those provided by the NHS. We also have quality and outcome framework with the annual reward and incentive program. For example, those doctors who achieve good results are given this reward and incentive. It is a voluntary process, not a compulsory. People can choose to be part of it. And awards are given to the clinicians or clinics that manage most of the common chronic diseases like diabetes and asthma. It is given on how well the practice is organized and how patients experience surgery. Surgery is not operation in the clinics, and the amount of extra services that they provide to children and maternity services. So based on this, if the health facility is providing all this, then it gets that award of what they call quality outcome framework. Regularly, patients are asked to provide their views in terms of how satisfied they are. Whenever they visit a clinic, they are followed with a text message to rate their experience. How was their experience? And some people respond, some people don't respond to these messages. But for example, out of the 77,850 participants, the quality of communication between medical doctors and nurses were, and the cleanliness and food and quality of food was good, and then the less positive results were about decision about their care and treatment, about the information sharing, about waiting times, about support after leaving the hospital. These are the points people mentioned they were not happy about, but those ones they have responded favorably. And patient experience, for example, in 2011 survey, 89% agreed that they were treated with dignity and respect. And in 2014 and 17, the Care Quality Commission, 4% rated outstanding, 86% very good, or sorry, good. Others rated 8% rated requiring improvement, and 2% rated inadequate. to the services they receive. Is the NHS successful with all what we have mentioned? I think I would say yes. It's still very popular with the public. It is respected by policymakers as a good system that is providing care to the people. When compared to international standards, it is still considered cheap. It's the comparison of our health system, which is provided based on taxation and free at the point of the use, is compared to be similar to the rest of Europe. It avoids problem of insurance systems, you know, it's quite tedious. It is funded by taxation and is comprehensive and no stigma in receiving care. So, for example, when you are poor, you cannot go to the best hospital, you are be seen as to be less dignified. But in the NHS, that is not there. And the budget is set centrally but distributed equitably. But, yes, it's a fact. Despite all those successes, it is inefficiently resourced despite increasing spending with growing deficits. That is one of the major drawbacks of the NHS. It is still driven by the provider, by the doctors, who have strong clinical autonomy and working towards patient preferences. It is struggling to keep up with the demand for services, raising costs for providing healthcare. For example, we could experience 44 to 54 billion funding gap in 2022, unless some productivity gains are delivered. It is seriously affected by employment crisis and future uncertainty after UK moving out of the European Union. NHS has some disappointments. One of the disappointments of the early NHS was the lack of innovation and efficiency. The managers have struggled to change service against the opposition of the powerful doctors. We have managers who struggle with the doctors whose demands are always more powerful. The short area of area health authorities gave way to district health authorities with family practitioners managing primary care separately. And for example, in 82, less than 10 years after the 74 changes, the experience is still integrated oversight has gone. In conclusion about NHS, first 25 years of NHS was a success in delivering free care to the whole population, but this has little effect on the health experience of the country. Financial pressures led to a rethink about the need to prevent ill health and contain the cost of services. Focusing on the causes of ill health brings even greater benefits to those with the greatest needs, and this has positive impact. And alongside this, better integrated healthcare, which means integrating prevention, treatment, and recovery, can have a major impact on the population health. So that is about the NHS. I don't know what is the plan here. Will people go to break or will you finish this? So we move to the American system now. In the United States of America, the system is quite different. For example, the government role, unlike in the UK, which is collecting taxes, allocating this money to different care providers. In the United States, the role of the government, for example, is always to deal with this fragmented health coverage. How to deal with it. So the enemy with the government is they are dealing with this fragmented healthcare because there are numerous private and public sources. The gaps of the people who are not insured are high, the rates are high. Obama tried to introduce Affordable Care Act in 2010, and this Care Act was trying to share responsibility between government, employers, and the individuals. So for the first time during President Obama's reign, they tried to pass this act, which is like making healthcare affordable to people who are not insured. And with that, it gives role to the government as well as employers and individuals to contribute in making that as possible. And access to affordable and good quality care, health insurance was what was. In America, they have got these two types of cover for people who cannot join private health insurance. And these are called Medicare and Medicaid. For example, the federal government programs for anybody who is over 65 or older and have some people with disabilities are covered by these Medicare and Medicaid. It's a conglomeration of federal state programs for certain low-income population. America has got two levels of government, the federal government and also the state governments. So this is a share between the two. Then there is the private insurance, which is regulated at the state level, and, Texas, whatever. And who is covered and how is health services financed? The figures we have is that 70% of the US residents receive health coverage through private health insurance. So you have 70% of the population who are covered by private health insurance. The government has nothing to do with that. Unlike in the UK NHS system where everybody is supported by the NHS. And the Obama Affordable Act increased the number of residents able to have health insurance coverage. For example, people who are required to have health insurance, and insurance companies were required to offer premium subsidies because of the, and it has expanded the Medicaid, and it required hospitals to accept Medicare funds, provide healthcare to stabilize any patient with emergency medical condition. So if somebody is taken to the hospital for emergency case, hospitals are required to stabilize that patient as part of the Medicare funds for people who are uninsured and unauthorized immigrants. And we have 8.6% of the population who is uninsured. They have nowhere to go if they need healthcare. It's a large number. Medicare coverage for hospitalization, for example, for over 65 people with disabilities and so on. Physician services, post-acute care, when people are discharged from hospital after and then voluntary supplementary program for prescription of drugs And the Medicaid here offers coverage in areas Medicaid has not, which is it offers cover to to those that are not mentioned above, and these include long-term care coverage, people with chronic conditions. For example, broad range of core services, including hospitalization and physician services, and the benefits vary between state and state. The American system has got this concept of cost sharing. Even if you are insured, you still have to contribute something to the cost of your care. So what we see here, that people are required to pay or to co-pay when they visit a doctor, when they go for hospital services, and when they go to buy their prescription drugs. They are required to contribute the cost of those. And the insurance plan includes deductibles, for example. For the out-of-pocket cost sharing with those who are on Medicare, there are deductibles for hospitalization and ambulatory care, for payments for physician visits are still applicable. And for Medicaid, they require minimum cost sharing because of the people who receive that or who has that entitlement. The way services are organized and financed in the US health system is the fact that these two, Medicare and Medicaid, they have public finance, for example, which is financed by a combination of payroll taxes and federal government revenues, while Medicaid is also taxed by, is funded by taxation, and this is administered by the states, whereas the Medicare is administered by the federal government. So the states here receive matching funds from government, from federal government, and they cover programs that under federal government guidelines. And these include federal facilities and veterans facilities. For privately financed healthcare, which could be for profit or non-profit, these are responsible to state insurance commissioners and the purchasing private health insurance for individuals as well as shared employers and workers. And for specialist care, private practice and hospitals, you have got these health maintenance organizations. To access those, you have to get a referral from primary care doctor, and it has a limit to the choice of specialists. It is provided, preferred provider organization is another group, and this has broader range of choices and direct access. So with this one, people don't have to be referred. They can choose directly themselves. For specialist care, for those who are not insured or who are under Medicaid, access is very difficult because they can be refused by the facilities to accept them due to low reimbursement rates. And there are multi-specialty and single specialty groups. So who see patients with other public or private insurance. For the non-profit, for example, which are 70% and for-profit, who pay for combination methods, including physicians who pay on fee-for-service basis, and there is increasingly physicians who are salaried by hospital employees. Now, the way the US health is financed, you have these different categories. For long-term care, it is people with chronic conditions. You have a mixture of for-profit and non-profit. and payment will depend on the type of provider and who is paying for it. For Medicaid, it provides extensive coverage for long-term care, and it varies from state to state, and it is means tested. Means tested means it checks how much people already have with them. So you have to produce your bank accounts, your savings to show that you really need to have that coverage. And for hospice care, which is short-term nursing services and nursing home, they can get benefit from Medicare, and you can be in the hospice for up to 100 days. And so with that, what I can summarize here is that the issues that health insurance is required for the American access healthcare in the US. In the US, healthcare can be expensive and prohibitive without insurance. And always, or quite often, even if people are covered by insurance, they still have to pay for payment. And there are different systems in operation. Some of them are managed by the federal government, some of them are managed by the states, some of them are for profit making, some of them are for not for profit. And then the benefits are different from one state to the other. With that, what I think, more or less, we try to cover the global health, how it has development from 1945 to 1960, and then post-independence. We look to the examples of the two countries, how they are structured and the philosophies behind each of them. The policy and management issues of the two health systems, how funding of the two health systems work, and hopefully you can draw lessons from these two case studies. See which one would you prefer if you are a decision maker? Which one do you think is good for whom? I mean, both of them are good, but they are, so one is good for somebody, another is good for another person. For example, the UK health system, it treats everybody equal. Even if you are a doctor working in that hospital, you still have to be equal to a patient who is coming from outside. So you might have seen during the COVID pandemic, even the Prime Minister was admitted in an ordinary hospital along with other patients. So that is how the NHS is. It has a long waiting list if it is not emergency. And some people do not want to wait. They want to be treated quickly. And sometimes while people are waiting, they develop complication or the conditions can get worse. On the other hand, and the good thing is we don't pay for it. On the other hand, you have got a medical health system where you can get access to treatment very quickly, but you have to pay for it. So for people who have got money in their pocket, who can afford, who are covered by insurance, the system works better for them. For the 8-point-something% who are not insured at all, it is a struggle for them. For those who are mean tested, that means they have to use their savings before they get entitlement for Medicare and Medicaid. It is a struggle for them. So with these two examples, I wanted you to think and vote for which one and why. Thank you.
So should we go for the vote now? And give the reason. Okay. So ladies and gentlemen, Dr. Maya has challenged us to have a vote which system is better and what is your reason? Anyone want to raise issues and give opinions? Don't say that UK is a better one because Dr. Maya is here. That's not it. He said it is better. Okay. Yes, please.
Thank you for the opportunity. Where I choose for I choose UK. What I choose is linear to overall. It's linear to overall because it's covered for because everybody can get care. They can get they can provide. But for US, is it IT? I think we use from the two models payment by the medical care. I think it could be the competition between one medical care to other. They can look our from one medical care to another medical care to become competitors. And then actually I have another question. Can I ask the question? My question is, what I know medical is basic need. And then from the medical system, we talk about the salary. And then it's become the common. How it's looked by the ethics, the parameter. The parameter when it becomes it looks like as the basic payment, and then it looks like as the common. Thank you, sir.
Okay. Can you please, I didn't get in there. Can you try to take, to raise in Indonesia?
Oke, sebenarnya untuk memilih saya pilihnya UK karena menurut saya itu selaras dengan overall. Dan kalau US atau tadi menggunakan model pembayaran melalui medical care akan menjadi kompetitor antara satu medical care dan medical care yang lain. Nah, pertanyaan saya, kapan medical kan tadi kita dijelaskan tentang fee melalui medical care. Nah, tadi ada salary dan berapa persen. Parameter untuk yang saya tahu kayak medical itu sebagai basic income. Kapan dia diberikan dari sultan as basic income? Dia sebagai umum. Parameternya harus seperti apa? Terima kasih.
Okay, thank you. You choose UK system. Congratulations. And this is because it is in line with the health for all perspective. And how and why US system will raise the competition within the military institution. And we asked about how many percent from the salary could be taken off to pay the tax. Because in the UK, so the government cover all, but they use the tax. And how the proportion from the salary of the people, or maybe the capital, yeah. And then also when we say which one is the basic demand and which one is the commodity, is it like that? And if it is like that, what is the parameter to decide, to define that this is the basic demand and this one is the commodity one?
Okay, let me first of all, the taxation in the UK, taxation system, there is no health tax. It's So you don't pay tax only for health. Depending on the income of the individual, it can go from 20% to 40% the salary. So, for example, 40,000 pounds a year, which is not a lot. 40,000 for 12 months. So you pay 40%. And that is not only funding health, it funds education for schools, it is funding health, it is funding social care, it is funding roads, it is funding water, and funding everything. So the government takes responsibility to use the money they are deducting from people to provide services to the citizens. And it's a progressive approach. I feel happy to say that because I see the money is used to improve the life that we are living. Some countries will pay tax. You don't see any improvement. You see the roads are holes. When there is rain, water is everywhere. You find electricity is not working. You find the taps are not having running water. You don't know where your money is going. So in terms of taxation, the proportion is higher if your income is high. Now, NHS only covers essential health needs. For example, if somebody wants to have plastic surgery to improve his local, you have to go private. In the UK, there are private hospitals who do those commodity sort of things. Which are not life-threatening or life-saving interventions. Or they go abroad where it is cheaper. Does it answer your question? People go to Turkey for now. People go to Turkey. They go to Eastern Europe sometimes to countries who are relatively forms of Bulgaria, Hungary, and
Yes, thank you. Anyone else? Yeah. Yes, please. Yeah, it's enough.
one teacher.
Oke, Ibu, boleh pakai bahasa Indonesia? Perkenalkan, nama saya Beda Beda Aureli Prasari. Perkenalkan, nama saya Beda Zahira Aurelia Prasari dari dipanggil Zalfa. Zalfa. Oke, dari FKG. Ya. Kalau menurut saya yang lebih bagus itu punyanya UK karena semuanya dianggap sama dan tidak berpengaruh sama siapa yang lebih besar, tapi berpengaruh siapa yang lebih gawat kondisinya untuk dirawat. Jadi boleh bertanya. Bagaimana kalau yang tidak bisa bayar pajak, itu apakah dia tetap mendapatkan perawatan? Terus apakah ada yang merasa tidak adil karena yang tidak bayar pajak ini dapat perawatan yang sama, sedangkan yang bayar pajak juga dapat perawatan yang sama, jadi masih tidak adil. Terima kasih.
Terima kasih, so nice. So Zava from dentistry, faculty of dentistry. She said that UK is better because it promotes the equality for the service for all the people, for all. And it is not influenced by which person is contributing either. They will give the same service. And she also asked questions about how about the people who can't afford the tax? If they can't pay it, such as they are unemployed, how about him? And also, is there any unfairness atmosphere or unfairness claim from the one who have a bigger salary because the proportion is just the same. So when you earn 10,000 and when you earn 5,000, you will be charged for the tax for 40%. Do they feel it is unfair? Yeah.
Okay. Dentistry is a very good job. So you want to consider coming there. Is the only profession which is private. So, no, there is no free dental treatment. Certainly should. It's out of the or the government pays. And they are in short supply because it's very difficult to get a dentist registered. Now, those who cannot afford to pay, who don't have job, they are not required to pay tax. So tax is only taken from people who earn. There are people who think that, for example, I pay tax, and this tax is not covered. Paying for people who have no jobs, it pays their money for them to live. It pays for their free accommodation. It pays for their free health care. It pays for everything. So for people who have no income, or whose income is little, very minimal, then they do not pay tax. But if they do not pay tax, that means they are not, doesn't mean they are not entitled for care. They still get the same quality of care as the need is. I met a nurse who comes to visit my wife, and she was looking different. She was, I couldn't recognize her. She said, "Don't you recognize me?" I said, "No, I don't recognize you. I am so and so, you know, I was very fat, very big. I had surgery of my stomach, cut into half, and I could not get the NHS to do it for free. So I had to go find pay money to have that surgery. So even health workers, they do not get better results when it comes to need. Everybody is equal, and I think people don't feel unfairly treated because people feel it is the obligation to support those who are in need. So people feel happy that their tax they are paid is used to help others who are in need, whether it is a need for survival, or whether it is a need for accommodation, or whether it is a need for health. Maybe there are people who feel, there are a lot of people who don't pay tax. Because if you are working in certain jobs, your tax is deducted from your salary. There are some jobs which are called self-employment. Yeah? Like if you are working for yourself, you have a shop, you have a taxi, yeah? You work privately, the government will not know how much you get. So it is entirely up to you to declare how much you work and go and pay tax yourself. So there are people who try to avoid paying tax. I feel it is unfair, they have to pay it.
Sudah clear jawabannya Pak Adi. Kita two more questions ya, from your colleague and also from you first.
Okay, thank you for the opportunity. May I introduce myself first? My name is Anantha Insyaallah. People call me Zola, and I'm from the property outlet district. If I'm being asked what the country should I choose between the UK or the United States, I will choose UK, of course, because the facilities or the equality they provide for the society. But I have a question for the professor. Maybe my question is a piece of cake or a basic question compared to the other participants, but I still want to ask why we compared these two countries? Why we compared the healthcare between the United Kingdom and between the United States? Why we don't compare the UK into the United Emirates Arab or Japan? Why we compare this UK and US? What's wrong with these two countries? Maybe this question is open to Professor, but I still want to ask. Thank you.
Thank you, it's very lovely.
I also want to ask why we should compare US in
Yeah, look, there is no justification why not compare UK and Japan. We could. I just wanted to introduce two case studies of two different systems. So we could compare. In fact, I was thinking to compare UK and India. And, UK and Canada, which is more or less the same, but I wanted to go two extremes. And I think even in Japan, they have the insurance system. Excellent social insurance systems. So the insurance system is not bad. If it is managed well, for example, in the case of Japan, South Korea, and others, Germany, they work very well. Because even those who cannot afford, the government pays for their insurance. So the government takes responsibility to pay the insurance for people who cannot afford to have private insurance. Yeah? Yes. But in the US, they tried to introduce this Obamacare to give some responsibility to the government, pay something for people to make sure that everybody is insured if they cannot afford the government to support them. But there's still a core payment mechanism. So even if you are insured, you still pay an element of it. Now, I think the question of which one you prefer is unfair. Because the US healthcare system is brilliant. Their hospitals are top class. They have got the best doctors in the world. They have got the best equipment, better than the UK. They treat many conditions than the UK does. And there are many people who are happy with their system because it is responsive, it is available at any time, but they are able to cover it. Depending on your experience. I had a very bad experience. I went to the US with my wife and my kids holiday to meet their parents because my wife's parents live there. And then after 2 days, she developed severe heart. And we came. We have to rush to the hospital. They said it is gallbladder stone. We have to remove it. Okay, so it's a very minor operation, and at the end they send me a bill of $60,000 for gallbladder removal. In the UK, my wife has been ill for the last 25 years. She gets treatment, and nobody has to pay anything. So my experience Exactly. I prefer where I am, what I see. I get treatment without question. Well, it depends on who you are asking. And when I ask my students these questions, I give them more background. I use two cases, for example, so and so who is rich, who has that, who cannot afford to wait for a long time. Which of these systems do you think? No, they say one thing. They say, "Oh, we think we should go to America." Okay, so I hope you. The idea is just to have to share with you that there are different systems. They are not perfect. Even the UK, with all the good things that I mentioned, it has a lot of limitations. There are a lot of unsuccessful stories. There are a lot of disappointments. For example, we are very bad in cancer because of the delay. And COVID has made things worse. For example, people have canceled their appointments every now and then. And then patients will have got serious conditions. The condition gets more serious and people die. Ambulances, for example, they were having a strike because they want more payment. During the ambulance strike, there were so many patients who lost their lives. But it is still not perfect. So any system might work if it's always if certain conditions are possible.
Last question, please, Katrina.
Okay, thank you for the opportunity. Because you asked us for quote, I go for UK. Yeah, I think all in this room will vote for UK because we are from a poor country. So the country has to be responsible for our health. Because you can see the health is a basic human right, so the country has to be responsible for guaranteeing the basic human rights of the community. I'm interested in your slide. I may miss that there is an interesting sentence for me, and I'm curious to know about primary health care and public health are seen as separate functions. Because in Indonesia, public health care, in our terms, is the main point of institution to do the public health function. So how is in UK? Because Indonesia public health community is Puskesmas is center for institution to empower the community to maintain their health in terms of to do the prevention, to promote their health. So how about in UK? And what institution do the role of public health? Thank you.
Yes, the UK, the concept of primary health care is not primary care. You remember in the morning when I was talking about the determinants of health. I say when these are the things that make people healthy or unhealthy, are we talking about health? Or are we talking about health? So if the concept of UK is primary care, doesn't have health. So it is the first point of contact that is set up for anybody in the country to have a doctor where you go and contact. In the UK, you cannot bypass and go to see a specialist in the hospital. You cannot bypass to go and see a physiotherapist, for example, a nutritionist, a dietitian. You have to go. So this is like a gatekeeper. Is a unit of care is supposed to provide basic essential care. And anything that requires further work or further treatment, then they can refer you to a specialist or a doctor. Now, primary health care, not mentioned, they have for prevention, that proportion, they have what they call the Public Health England. They have, I will talk about it in tomorrow. They have Public Health England that is responsible for all activities that are related to health promotion, health disease prevention, related to immunizations. All this COVID story is all coming under Public Health England. They work very closely with different agencies, with the schools, with the employers, with all the occupational health issues. They all come together. That is the way they distinguish between.
So, ladies and gentlemen, I think we have come back to the end of our session today, and I personally thanking to our distinguished guest lecturer, Dr. Maria Omar, for your time, your dedication, and there are so many insights that he delivered to us today, and also historical of the health system and comparative analysis about the two health systems between US and UK, and we can compare later. I think I would like to give an assignment for my students here to give a comparison between UK, US, Indonesia, and Thailand. Because in Southeast Asia, we know that Thailand has a better health system in Southeast Asia. Okay, so I think this is the time to say Alhamdulillah Rabbil Alamin. We have 1:20 now here. So, ladies and gentlemen, once more, let's have a big applause for Dr. Maria. We are waiting for you tomorrow. We are going to have another 2 sessions, which is more hot to discuss. So I deliver back to our Master of Ceremony, Ibu Rasma, please. Assalamualaikum warahmatullahi wabarakatuh. Have a nice day. Thank you, Ms. Khalifa. Ladies and gentlemen, here we are finally at the end of our guest lecture for today. Thank you, Dr. Mai Omar, for a good lecture. We hope that you have the time to learn again in Hasanuddin University. But before we close this guest lecture, I would like to ask Mr. Omar to say hello in our local language. Is that all right? If you want to try to say hello to us with our local language. Yes, just follow it what I say. Okay? Jadi kita minta Dr. Omar untuk bisa bahasa Makassar ya. Jadi kita coba dengan bahasa paling gampang Aga Kariba. Coba. Just follow it up. Aga. Aga Kariba. Aga Kariba.
Aga Kariba.
Nice. Thank you, Dr. Omar. And now we will move to the next event token appreciation that will be given by a head of Master of Administration, Hospital Administration, Dr. Shahir. Please. The first token appreciation will be given to Ibu Arifah as a moderator.
again appreciation for our moderator, Ibu Arifah, from Head of Administration Hospital. And now we are invited, can we invite Dr. Omar? This is the appreciation for Dr. Omar from Dr. Syahrir. All the children in this room to take a picture together. And hello.
Ya, selesai.
Which is good.
Ya, ya.
All in this room to take a picture together. Please join.
Lantai apa?
Silakan Bapak Ibu yang masih boleh berfoto bersama.
Masih ada, masih moving. Hah?
Yang peserta juga boleh berdiri, boleh mendekat kita foto sekali lagi. Boleh angkat. Boleh merangkak ke depan dan ke tengah, Bapak Ibu, biar lagi.
Kameranya mau kau.
Ada yang benar sekarang. Kira berapa lama?
Iya, siap. Oh iya, siap. Iya, ya, amin, beliau. Iya, siap.
Sini lagi apa yang mau dipersiapkan? Kan intervensi.
Oh iya,